Hi, everyone. Welcome back to today's Grants and Sponsored Research Initiative, the GRIT seminar, hosted by the Research Program on Children in Adversity at Boston College School of Social Work, in collaboration with the University of Rwanda's Center for Mental Health and the National Child Development Agency. My name is Laura Bond. I'm a doctoral research intern in the RPCA, and I'm a social work student at Boston College. Prior to coming to Boston College, I worked as a program manager for Catholic Relief Services in Lesotho, Afghanistan, India, and Northeast Nigeria, managing large-scale education, child protection, and emergency relief projects. As a former implementer and now a current PhD student, I'm really excited by the idea of implementation science and the way we can use implementation science to bridge the gap between research and practice. So I'm so pleased to welcome Dr. Shannon Dorsey for today's GRIT series. The GRIT seminar series began as part of the U19 Youth Forward Implementation Science Hub, funded by the National Institute of Mental Health and their global network of U19 scale-up hubs. Our other partners in this work include the Essence and Shine U19 hubs, the University of Rwanda Center for Mental Health, and the University of Sierra Leone and McKinney University. Our seminar series will conclude next month with our final GRIT speaker, Dr. Emily Harose from the Johns Hopkins Bloomberg School of Public Health. Dr. Harose will share her expertise in dissemination and implementation science with a focus on low resource communities on Tuesday, December 14th at 9 a.m. Eastern Time. So please check our website for more information. I would also like to announce that the RPCA is currently recruiting for some new important positions, both based in Boston and abroad. If you're interested, please visit our website and contact us for more information. And now I am pleased to introduce today's speaker, Dr. Shannon Dorsey. Dr. Dorsey is a professor and associate chair in the Department of Psychology at the University of Washington and adjunct professor in global health and psychiatry. Her research focuses on treatment effectiveness and implementation science, specifically for children and adolescents receiving care in low and under-resourced contexts and settings. These include publicly funded mental health in Washington state and mostly rural areas in low and middle income countries. She has focused on how to address the mental health treatment gap by training and supporting lay counselors to deliver mental health care. She has also focused on supervision as an implementation strategy to support successful implementation of mental health treatments. All of her work includes strong partnerships and collaborations with communities and practice partners. One current NIMH-funded study examines implementation policies and practices associated with successful implementation of a group intervention in the health and education sectors in Western Kenya. She also co-directs an NIMH-funded center, Impact, focused on optimizing mental health care for children and adolescents in under-resourced settings. So today, Dr. Dorsey will present a specific study in Western Kenya, building and sustaining interventions for children, also known as BASIC, to feature examining both clinical intervention effectiveness and implementation outcomes. The talk will feature practical implementation science with a focus on community and stakeholder collaboration and leadership to support successful implementation of a mental health intervention. BASIC aims to identify implementation practices and policies that support successful implementation in health and education. Working with stakeholders and community members, they built a practical low resource implementation support program that could be delivered by peers. So we are thrilled to welcome you, Dr. Dorsey, and now we'll turn it over to you.
Wonderful. Good evening. Good morning, everyone. I'll go ahead and share my screen, hopefully successfully. So I'm really excited to join you today and discuss this topic. This seems like an incredibly exciting seminar series. So part of the focus of what I'm going to talk about today is not new to many of you, but it's the fact that if you look around the world, mental health care is relatively scarce. And in 50% of the population worldwide, there's 2 psychiatrists for 100,000 people. I'm going to be talking about a project in Kenya today, but it's not just an issue in low and middle income countries or even in rural areas, but also worldwide, because even in Washington state, we provide care to a lot of areas in Alaska, and in the most remote areas in Alaska, there's also issues with access to care, despite the fact the U.S. is Alaska is part of one of a very high income countries. The other thing that's important to recognize is even in a city like Seattle, which is mine, even when mental health care is available, it's often not adequate to provide care. So in a study looking at minimally adequate care for depression, in high income countries, still only 1 in 5 individuals got adequate care for depression. They may have gotten care, but only 1 in 5 got care that you would consider adequate to actually address the mental health condition. In low and middle income countries, that threshold is much more exacerbated. So only 1 in 27 get minimally adequate care. But it's very clear that we're not getting the care that is needed to most people around the world, whether it's a high or low or middle resource setting. In a lot of ways, it's not really an issue of are there treatments, because here I just have a bunch of named mental health treatments for child and adolescent mental health problems. But in part, the issue is support. So, interventions are often not easy to learn. They take training, they take support to scale them up and to deliver them effectively. And so that's kind of going to be the focus of my talk today. I'm going to start with some terms, and I'm going to return to this slide a good bit. A colleague of mine, and some of you may know Jeff Curran, has tried to work on how we can use more plain language and simplified terms that are non-jargon based so we can better connect with stakeholders, partners, implementers, and using non-jargon terms. These are the more jargon ones here. Is also incredibly useful, and I've used some of the terms I'm going to use here that are more plain language but describe each of these, even on calls with NIH project officers when you're trying to differentiate studies focused on an intervention or a treatment, kind of this square here, versus things that we do to support the treatment. So before I get started, because I'm going to build this using our basic study, I just wanted to start by acknowledging my collaborators, the funding of NIMH, and the sites, centers, and folks who make this work happen. Predominantly, I wanted to recognize Augustin Wasonga, who's my colleague and the head of ACE Africa, and Kate Wetton at Duke University, with whom we lead this work. So returning back to the terms, I think one of the complicated things about implementation science is distinguishing between what we do to support an intervention and the intervention that we're testing. So one of the things that Jeff Curran has done in this paper called Implementation Science Made Too Simple, but I think it's probably Implementation Science Made Just Right, is that when you think about the intervention, practice, or innovation, that's the thing you're focusing on. So these are terms from implementation science and broader areas, services effectiveness, but I'm going to try to distinguish between them. So when we talk about the intervention, the practice, of the innovation, and implementation science, that's the thing that's being delivered that you think may need support. So it's the intervention, but it's really a focus on the clinical treatment or the thing. So for us, that thing in basic is trauma-focused cognitive behavioral therapy. So this is an evidence-based treatment for children and adolescents who have mental health symptoms subsequent to trauma exposure. In basic, that trauma is death of one or both parents. It can be delivered individually or in groups. In basic, we deliver it in groups, and I'll talk about that in just a second. But it teaches coping skills for dealing with emotional distress, related to trauma exposure, like changing the way that you think, doing new things to calm your body and relax. In the middle of the treatment, we have kids face up to what happened. So they tell their story or they talk about the traumatic event they experienced. That could be sexual abuse. It could be experience of war. It could be experience of a serious medical injury. In basic, it's parental death, but they talk about the traumatic event that happened. And then towards the end of the treatment, they process what happened. So what meaning did they make of it? If they viewed it was their fault, can we change that thinking? And we also work through trauma-focused CBT to build caregiver or parental support. If you're interested more in the thing, there's some references here. There's an online training. And the neat thing about this treatment, as I'll talk about, is this thing that we want to implement has some nice evidence in Zambia, the DRC, Kenya, and Tanzania. So this thing that we're implementing in Western Kenya has been tested in these regions. So the TF-CBT that we're delivering has been adapted to be appropriate for the local context, the local culture. We do groups. This adaptation was not done by me because I'm not Kenyan, but I worked with my Kenyan and Tanzanian colleagues to adapt the intervention to be most appropriate in their setting and with the families and kids that they work with. And we've published some on that. Some of the papers are below, and then others I'm glad to share. They're all on my lab website, and I'll show you the website at the end. But we deliver this adapted TF-CBT in groups because that helped normalize and decrease the stigma of experiencing parental death. Children receive either 8, we've now gone down to 8 to help with scalability, but they used to receive 12. Children meet in groups of usually about 8-ish, 8 to 10 kids and a counselor and a support counselor in case any individual child is having a problem. And then their guardians meet in a group with a counselor. In the middle, when they tell their story of the traumatic event, we do that in 2 to 3 individual sessions so that, one child is not being further triggered or bothered by hearing the story of another kid. So that's done individually mid-group, but the rest of the intervention is in a group setting to destigmatize. And in BASIC, we started in Tanzania with a pilot study. Then we worked on testing the intervention in Kenya and Tanzania. And then now in BASIC, we're doing more scale up specifically just in Kenya so we could really focus on the local context. So with the effectiveness research and implementation science, when you see the term effectiveness research, that's really looking at, does the thing, the intervention that you're interested in, does receiving that thing result in positive impacts on clinical outcomes? So for us, in terms of our effectiveness research, one of the things that we did is after we did the pilot study in Tanzania, which was a small trial with 60 kids, it was funded by NIMH, and it was designed to do the adaptation, see if it was appropriate to do a trauma-focused intervention where kids talked about parental death. And then after that pilot study, our effectiveness research involved a large randomized clinical trial in both Tanzania and Kenya, where the experienced Tanzanian counselors were trained to be the supervisors and the trainers for a new set of Tanzanian counselors and Kenyan counselors. And so that study has been published in JAMA Psychiatry, and you can check that out. So that's part of our effectiveness research there. Now, one of the next things that I wanted to focus on is effectiveness research. The way I just described it, it was 6 counselors in Tanzania, 6 counselors in Kenya who were trained by our original counselors that moved up to being trainers and supervisors from Tanzania. But that's 6 counselors in each country. That's not going to scale any treatment, and we all know that. So we were interested in, what would you do if you wanted to actually provide treatment at scale? And this is a picture of Bungoma Township. And we were interested in if you wanted to continue the effectiveness research, what would you do and how would you provide the treatment and test that it was effective, where you could provide services both in, an urban township like this, but also in a more rural area, and what existing systems could actually provide care with few or minimal new resources. There's so few resources for children's and adolescents treatments that you can't just, I think many of us know, you can't just look at what you could do in an urban area because the experience can be very different in a rural area. And so solutions that are going to actually be scaled up and sustained to help children and adolescents need to be able to be delivered in urban and rural areas. So in 2015, we spent some time with our colleagues in Kenya who had been delivering this treatment. And one of the things that ACE Africa, so Augustine Wasonga, the experienced counselors there, one of the things that they had done is worked a lot with teachers in schools to deliver clubs that supported children who had been orphaned. And they worked a lot with community health volunteers to deliver a wide variety of programs. And their perspective was, if you were going to scale up and deliver Pamoja Tunawesa in a way that children could actually get benefit at a much broader scale, The treatment would be delivered either in the education sector or in the health sector by community health volunteers who are the last mile of healthcare, so moving from the health facility into the community. So that was the grant that we wrote. And the grant was to test, could you do TFCBT in these settings, and what would be needed to support TFCBT in these settings. And so that moves into, back to the term slide, that moves into the implementation research. And so in the basic trial that we developed together in 2015, that really would be moving into implementation research, which is how do you best do the thing? What is needed for sites, people, individuals to deliver the thing, the TFCBT or the Pomocha to Nueces well? So in basic, our focus, the study that I'm going to kind of thread through from here forward, is we were really interested in what are the day-to-day practices, what are the policies that would support successful delivery of trauma-focused CBT or Pomocha to Nueces in these two sectors that the experienced counselors and the NGO who was delivering care and services in the area thought would work. So how do we successfully deliver, scale up, and sustain this treatment or this thing and other treatments for children and adolescents? And so this is the focus of implementation science research. And I know many of you are aware of implementation science research, but hopefully these terms might even help you as you have conversations with community mentors, stakeholders, or funders who are newer to implementation science research. So this work is about how do you help people, places do the thing that may have been found effective before, but may need support to be scaled up or sustained. Oops, sorry, my computer is quite sensitive and moving forward on me in a way that I don't want. Okay, here we go. So for basic, what we wanted to know is what do organizations, leaders, the lay counselors, co-workers, and communities need to do? And we really were interested based on ACE's experience working both with health and education. These are quite different sectors. So what might teachers need in education that might be different than what is needed by CHVs in health? So teachers have a pretty clear organizational structure, head teachers, deputy teachers, a set schedule. Community health volunteers, some have a stipend, but they're truly volunteers and they have a little more freedom of movement. They might go to the health facility and report once a month. Some might be in the facility more often, but they have a lot more freedom, but they also have a little less of a daily kind of organizational structure. So to try to think about in implementation science research, how do we support this thing, this intervention being done well so that it can be effective and have a positive impact? What we wanted to think about is what implementation strategies might be needed to try to help people, places, and sites do the thing. So in our work, we already had a set of implementation strategies that we were using. These will be familiar to many of you. We were using task sharing and task shifting, where treatment delivery was by non-specialist lay counselors. We promoted adaptability because this treatment was developed in a Western high resource setting. So we talked a lot about the recipe, which is delivering coping skills, helping children face up to the traumatic event, but that you would be spicing it up. So you would be adapting and changing things to be appropriate for the kids in the room with you, to be appropriate in the local setting or the local community, because it might be different in a very urban area, a very rural area. We made training dynamic. So all of our training has a lot of active practice, feedback, experiential activities where you try out the clinical tools. We've always provided regular clinical supervision that involves a lot of role plays. And we were using train the trainer strategies. So I did the first training, but as quickly as I could, I was not the trainer. And the Tanzanian experienced counselors were the trainers. And then in basic, the Kenyan experienced counselors are now the trainers. And if you're interested in seeing the types of things that are called implementation strategies, I put a reference at the bottom, so you can check out Byron Powell and Tom Waltz's paper where they list 73 implementation strategies. But these strategies are mainly focused at the counselor level. I don't know if you noticed that while I was listing them. They're not really about how would you support a leader or how would you support a site or an organization. So in basic, that's what we wanted to learn. And ACE had done some programs in schools. They had done many programs in health extension, but they had not done a mental health treatment in schools. They had not done a mental health treatment using CHVs. These were some of the areas that came up when we were talking about what would the treatment look like in education, what would it look like in health. Teachers have a full-time job. They're teaching. So to be able to deliver a mental health intervention, there probably has to be some kind of workload adjustment. So what might be an implementation strategy to support that schools can still meet their educational mission? Leaders probably need to signal that this is important, because in the context of many things to accomplish, if leaders aren't signaling that this treatment is important, spending time on this treatment is important, delivering is important, then it might not happen. So we were curious about, what needs to happen from the leader level, what needs to happen in the community, given that this new program may be viewed positively, or given that mental health can have a stigma, what needs to happen there. So while we had implementation strategies in place in our earlier effectiveness research, these are the types of things we were interested in for the basic trial. And what we wanted to know is, if we do things to support delivery of this innovation, this intervention, or this thing in the simplified terms, what would show us that it was being done well, and what would show us that it was successfully implemented? And so that's where implementation outcomes come into play. And with the implementation outcomes, the more plain language definition is just how much and how well do people and places do the thing or the intervention that you care about. So for us in basic, we were interested in adoption. So do people take up the intervention and begin to deliver it? Fidelity, so they're allowed to adapt it, and they should adapt it to make it appropriate, but do they actually do the essential elements? So do they teach young people coping skills to deal with the traumatic event? Do they have kids talk about the traumatic event that they went through? And then the other outcome we were interested in is it sustained? So 2 years later, are counselors, schools, and sites still delivering the intervention? So those were the implementation outcomes that we were interested in. And that was how we defined if the intervention or the thing was being delivered successfully. But here too, we did have an intervention effectiveness aim. So you can see in the second aim here too, we were still interested in child outcomes, because I'm not sure that effectiveness research is ever over. We kind of were changing who delivered the treatment. So we wanted to know, when teachers deliver, when community health volunteers deliver, is the treatment still effective? And we wanted to see with a lot more children. So this trial has 1,000 kids who would receive TF-CBT, over 1,000 kids who would receive TF-CBT. And in the randomized clinical trial that I showed you in JAMA Psychiatry, 320 got TF-CBT and 320 had usual services. So this is a much larger trial. Also, we were interested in finding out if counselors and leaders from initial schools in the education sector and counselors in the health sector, the CHVs, if we could learn from initial sites to build a plan that would support the implementation strategies, so support doing the intervention well. And so what we wanted to do, as I'll show you in just a second, is implement in a few sites, learn from their experiences, and then collaboratively with sites, with sector leaders, build an implementation support plan to help the next sites deliver successfully. So in our work that we had done already with ACE and with trauma-focused CBT, we already had local experienced lay counselors who were delivering the intervention, who were leading the intervention, who were the trainers. And then what we hoped to do was, from counselors, also build this implementation support and leadership. In high-income countries around the world, often implementation support is provided by external facilitators. It can be an expensive strategy. We felt like, and I know others agree, we thought that experienced counselors who've delivered, they might actually be in just as good, if not a much better position to provide implementation support, because they have successfully delivered within their own setting. So we underwent a series of work between January 2018 and September 2019. And we're trying to write up these methods now so that others want to follow them, they can. But basically the team at ACE Africa trained of experienced lay counselors. We went through a train the trainer process, and then they trained brand new lay counselors in health, so community health volunteers, and teachers in education. And then those lay counselors delivered TF-CBT to exactly 256 kids. And then we used a mixed method approach where we asked them a lot of qualitative questions. What supported leadership in what supported a successful delivery in your setting? What did leaders do? What did your fellow teachers do, fellow CHVs? What were the barriers you ran into? What did you need to deliver? And then we coded those responses. And then we brought together stakeholders from both sectors and counselors from both sectors and leaders. So we had the Ministry of Health there, we had Ministry of Education representatives there. And in a large meeting, which we called the Basic Collaborative Meeting, we met together to review what we had learned. And we used plain language terms to describe things that we had learned. So some of you experienced with implementation science, you may be aware of a term called implementation leadership or implementation climate. And what we had done right before this big collaborative meeting is the ACE counselors and myself and others worked to make plain language definitions of each of those. So for implementation leadership, what we did is we said leaders who are passionate, enthusiastic, and supportive of Pamoja Tunawesa. And so when we presented findings back to this large group of CHVs, counselors, stakeholders, we used plain language terms so that everybody could engage in what we had learned to try to build this implementation facilitation or implementation support plan that we would use for the remaining sites going forward. And what our goal was to identify when you're starting to deliver a thing, a treatment, intervention, what do you need when you're getting prepared and in pre-implementation? What do you need as you're delivering? And maybe that's like right as you start, and then it's 4 or 5 weeks in. And then when you're looking towards sustainment, what do you need? And we wanted to build a low resource, minimal touch point implementation support that could be delivered by experienced counselors across these phases of implementation. Dr. Rosemary Mesa, who's a former graduate student of mine and now a research associate at Kaiser Permanente Washington Health Research Institute. She had a diversity supplement to BASIC, and so I'm going to be presenting some of the work that she led, and so I wanted to introduce her to you before I moved on. So what we did is our goal was to do this work that you see cascading down, and then to use what we learned to support the rest of the 40 schools and the rest of the 40 communities. So what did we learn? So when 10 groups of teachers, 10 groups of CHVs, so it was 10 schools, 10 communities delivered, one of the things that we learned, and it's probably not surprising from what I described earlier, is that teachers really did need workload adjustment to attend the training. They needed workload adjustment to deliver Pamoja Tunawesa so that some of their duties would be on other teachers or leaders thought through when they could deliver. CHVs didn't necessarily need those things because of their flexibility. Urban schools versus rural schools, they were more likely to list workload adjustment as a facilitator of successful delivery. And urban schools, because they have a lot more teachers mainly, they were able to do a lot more varied strategies to adjust workload, like assign some of their duties to other teachers, adjust their individual schedule, make adjustments to the school schedule, and exempt teacher counselors from meetings. That was not as true in the rural schools. And we felt like these were things we really needed to know about how you help people do the thing, because there were some differences across the sectors. And even within a sector like education, there was a difference by what type of school you had. So how many teachers you had to bring to bear on what was needed. So this was why we thought that preliminary work, what implementation strategies might be needed, was important. We also learned a lot about attitudes that individual counselors had and what leadership could do there. So you can see on this slide that a lot of teachers and CHVs talked about the importance of having a really positive attitude about Pamoja Tunuwesa, and that people were more likely to have a really positive attitude and be excited about Pamoja Tunuwesa when their leaders were positive, passionate, and supported Pamoja Tunuwesa. So that's our plain language term that I mentioned for implementation leadership. So that suggested to us that our implementation support program, one implementation strategy, would need to be building leadership support. The other thing that we saw is teachers really talked about, 72% of the teachers talked about how important it was for fellow teachers to support Pamoja Tunuwesa. So when fellow teachers supported Pamoja Tunuwesa, they were more likely to release children to attend groups. They were more likely to support children coming to individual visits. And we did provide the intervention during games time, so when children had some flexibility, but some were still had times where they needed to be in the classroom. And teachers were much more likely to report that their fellow counselors were supportive of the program when there was high implementation leadership, so leaders were passionate and supportive of Pamoja Tunuwesa, and when the school had an overall more positive working environment. So what we did is we took these findings and we brought them to the basic collaborative meeting. So you see a picture of the basic collaborative meeting on the left. And our goal was to here share what we had learned, some of the things I just presented to you, make sure it fit with people's experiences. And this was all led by ACE Africa and by the experts. We were just kind of there in the back of the room as the collaborators. And then to elicit from people, based on what we've learned, what do you think needs to happen in terms of supporting people for workload adjustment, supporting provision of resources? I didn't mention all of those results, but we also learned a lot about resources, probably no surprise to anyone else. But when you were beginning to implement Pamoja Tunuwesa, if you knew you had chalk for use on the blackboard, if you knew you had paper, if you knew you had a dedicated room, more support to plan for that at the beginning was helpful. And so we wanted to elicit, how would we build a program that counselors who were in the room at the basic collaborative team could deliver to support new sites. And so we wanted to have options for brainstorming. We had small group methods. And then we wanted to have folks come together in small groups by sector and really try to say, okay, if these are some of the strategies, these are some of the things we need to address, what are the strategies that would have the highest impact of creating workload adjustment and would be most feasible? Because some strategies are super impactful, but they take a lot of new resources, or they take a lot of new time. And we were hoping to kind of hit the sweet spot of what are the strategies that would have high impact, but also high feasibility. Oops. So one of the things that Rosemary did as part of her diversity supplement that she had to basic was to really work out a plan that we could make implementation strategy menus where sites could match what they wanted to do to a goal. So if a goal was workload adjustment and schools needed to figure out a workload adjustment strategy, based on whether you were a rural school or an urban school, you could look at a menu of things that successful sites had done before. You could also tailor your own intervention or tailor your own strategy, but you also could learn from counselors delivering the strategy from an experienced site, what had been successful in urban schools before or in rural schools. And you could use that menu to figure out what solution or strategy you wanted to do based on the goal. And then our next thing that we did once we built these is you can see Lillian here, who's an ACE trainer and consultant. So she has expertise in the intervention, but you can also see counselors here. And then the woman in the red who's speaking, she is an experienced community health volunteer who participated in this collaborative meeting, and she's leading the implementation, coaching, and support meeting with new counselors who are being trained. and walking through these menu of strategies, and with the CHVs, and then also with the community health extension worker, picking which strategies do you think might best support your site in delivering effectively. And what was neat about this development process that Rosemary led in part to develop the coaching intervention, which was part of BASIC, is we were looking at research recommendations, existing tools, end user feedback. So what did counselors who delivered say they needed? We developed a product, which was this work plan with the menus. We had follow up on what people thought they might do. And we had 6 meetings, which were then reduced to 5 over these phases of pre-implementation, implementation, and sustainment. And what we were also able to do in some of Rosemary's work is take a look at what do people actually do once you build a support plan and people make choices. So I'll show you that quickly so that we leave time for questions. But one of the things that we saw, and this slide is a little bit busy, but we saw that in the work plans, people had a variety of strategies, most of which were around supporting the intervention or the thing itself. Some were targeted at supporting consumers, so guardians and children to attend, to engage successfully. Some targeted the organization, some the community to get out to like the Chiefs Barraza to do presentations to reduce stigma and community buy-in. Some targeted the provider. And then here's where the majority of strategies were. So not surprising, most of the strategies were at the implementation phase, but a good number were at pre-implementation to get folks ready to deliver. And then there were things that needed to be done as well at the pre-sustainment and sustainment phase. And then you can see that like with workload adjustment, looking across all of our schools, urban and rural, you can see there are a variety of types of workload adjustment people did. There are a number of different folks who were delivering the strategies. So head teachers did a good number. Teachers also did a lot, but there were also things the deputy teacher took on, the counselors themselves, the supervisors. And then you can see some of the other data that from these work plans we've been able to extract. So here's what we learned we thought you needed to do. Here are the choices that people made. So we were able to see what were the targets, what was done, who did it, when was it done, the dose, so are these things that have to be done weekly, monthly, and then if they were completed, because sometimes without follow-up, strategies get started but aren't completed. So in each meeting, the coaches would follow up on the past one. I know you said leaders needed to do this. Did it happen? Is there any follow-up needed? And last thing I wanted to present before opening up for questions is in AIM 3 of BASIC, what we do is try to look at what are the recipes of implementation strategies and activities that are needed to support sites to successfully implement Pamoja Tunawesa. And we know schools and sites within education and sites within the health sector probably would do different things. And there's no one size fits all recipe. There are lots of recipes of success. So there's a neat approach. It used to be more called qualitative comparative analysis. Now coincidence analysis is more the term, but it really lets you look at recipes. So you can, if each case is a school here, so case 1 maybe has a leader who signifies, support. They had workload adjustment and they had resources. But they didn't have counselors who started out with a positive intention. They still could have high fidelity. Where in another site, you have counselors who started out with very high positive intention, really committed to Pamoja Tunawesa. In some cases, those counselors might be successful even without a leader who highly signifies support. So you see here, all these sites have high fidelity, but they have a mix of different recipes leading to success. And so we're really excited to conduct this analysis in AIM 3 of BASIC to really try to see what are the different recipes, because then we can give practical guidance to sites. You know, if you have a highly supportive leader, probably some of these other things could be okay, even if they're not strong. But when you don't have a highly supportive leader, you really need these deeply committed counselors and so on. So there can be this recipe of different things. You can see that I have yes for high supervision for all, because that has always been an implementation strategy that we thought was needed. So counselors, for them to deliver well, they need support in the thing or the intervention to deliver well. So you can see that one has a yes, but others vary with yes and no. So I wanted to stop there and leave time for questions. Thank you for letting me do a quick run through basic and terms around the implementation science.
Thank you so much, Dr. Dorsey. This was really interesting and important for us to all understand how effectiveness outcomes are so tied to implementation outcomes and strategies. And so to start us off, I'll ask the first question, and I think we'll move to the chat, and we have some pre-registration questions we can get to as well. But I'm so curious, especially with your last slide about your coincidence analysis, if any of these elements that you spoke to could be shared across all interventions that are using lay workers to deliver evidence-based mental health interventions, and how, as a researcher, you balance the need to have a fidelity tool that's specific enough to your intervention, but also perhaps broad enough that there are these common elements that can be shared by other organizations or researchers that are trying to measure fidelity in their own interventions.
Yeah, great question. We designed the study so that what we learn about what is needed should be generalizable across other interventions, because we're trying to study things that are less thing specific, less intervention specific. So like leadership support, supervision, none of those are specific to trauma-focused CBT. So we do hope for the findings on the recipes to be relevant, at least to delivery of interventions in schools or by community health volunteers. The fidelity measure is specific to trauma-focused CBT. It was co-designed with the experienced counselors in Tanzania and Kenya. In other work, I've worked on common elements interventions here. So you could extract from our fidelity tool to other interventions and leave out something like the trauma narrative component when they talk about the traumatic event. But we do a fidelity that is both TF-CBT specific and spice it up or competency specific. So the competency part would directly be relevant to other interventions. So and they get scored on both, and they're scored by the Kenyan trainers and counselors. So the competency part is like, do you tailor to the kid in the room? Do you validate? Do you normalize? Do you praise? Do you make it fun? Do you tailor to the level of reading and age of the child in the room? So that part's directly relevant. And some of the other aspects are a mix of TF-CBT specific and common elements. So some you'd have to cut out, but some you could use.
Thank you.
Oh, I should also say our fidelity measure, we do not do any recording or coding. It is based on one of the Kenyan trainers joining the group and observing. So they do all the fidelity based on observation of a part of the session. And then that directly informs the supervision and is resource efficient because they can observe and then meet with the counselors and give some feedback.
You want to open it up to the chat now? Are there any questions?
We're also going to open it up to the room as well. Eric, I don't know if you have a question. No? Okay. Yeah, I'm just going to go through the pre-registration.
Okay. Is there anything else in the chat
No.
too? Okay. So the first pre-registration question that we have is someone would like to know how long it takes for the peers to understand and implement the intervention. Is the level of education of peers influential in their understanding of basic? And then who would ultimately be responsible for the sustainability of the intervention? So I think some of this you've touched on in your presentation already, but maybe if you could speak to how the level of education in some of these lower resource settings does affect maybe fidelity and sustainment.
Yeah, in general, I don't think education has anything to do, formal education has nothing to do with how well you can deliver an intervention. A lot of the intervention content is written, and I'm trying to move away from that. We actually had a counselor who was amazing in Myanmar who could turn some of our written step sheets, we call them step sheets because they're like steps you follow. We try to simplify our materials, which is part of how We can train a variety of people. Some of the best folks at connecting in the community are not people with a bachelor's degree. They're not people with a master's degree, right? So we look for good people skills, folks who are open to coaching and learning and growing, who don't mind being given feedback. And we do need people in basic, our counselors, CHVs, and teachers. Everyone does have to be able to read well enough to follow the step sheets. For teachers, obviously that is never an issue. For some community health volunteers, especially some of the older women, that may be a little bit harder, but it's been fully successful because everyone's been able to read. But I would like to move away from having the written piece, because for me, that's the only place that education comes into play. I think experience matters more, ability to connect with people, to be warm, to be willing to practice. But I don't think educational level plays a role. And in fact, this is one of the issues in contexts where there are lots of mental health professionals, is those contexts can be less open to lay counselors, probably to their detriment, because people who are good connectors and are already in the community are going to be much more accepted and better at delivery. But we often have this educational component that will drive who's selected. So hopefully that answered it a little bit.
Yes, thank you so much. Another pre-registration question that we have is asking about the potential for school peers to be a support team in delivering a mental health intervention. So even thinking about moving beyond teachers, I know there are quite a few peer-supported delivered mental health interventions, but would that be perhaps a challenge for delivering a peer-supported mental health intervention in a school where peers are quite young?
Yeah, so in primary schools, I wonder if it would be hard, and someone actually would have more expertise than me on this call probably. But if you had kids from secondary school who could come in, or older primary schools, I think there's so much that peers can do. In Washington State, we use a lot of peer support, and families are often much more likely to engage with a peer and to feel that the peer really understands their experience in a way that a counselor may or may not. So I would love to see more peer work. In this particular intervention, I probably wouldn't do the trauma narrative with a peer where the child walks through the details of their experience. But we know that trauma treatments can be effective even without that, as long as the child is bringing to mind what happened and they're thinking about it and they're doing what we call exposure. So they're thinking about when my mother died or when my father died, even if they're not telling the detailed story. And that's really just a confidentiality issue. And that's just one element of the trauma-focused CBT. So I think peers could absolutely lead kids through. One of the skills is cognitive processing, but we call it thinking in a different way. So a peer might be even all the more effective in helping young people think through, how could I think in a different way about this experience of having my parent die? Because if it's a peer who's had a common experience, they may be a lot more likely to immediately destigmatize by being able to lead a group in that. So I love the ideas of peers, and would be really excited to learn more from others. And a colleague of mine, Ann Mwayo at the University of Nairobi, is really interested in peer delivery. And so we've been talking about a lot of things there, but it's less my expertise, but incredibly exciting.
Thank you. And now we'll move to questions in the chat. So we have a first question from Ursula, but anyone else feel free to ask questions in the chat function as well. And Ursula is asking, how are the interventionists selected? And are there cases when the interventionists are resistant to components or messaging in the program? What strategies are utilized to work with these folks and protect recipients from potential harm? And Ursula, please feel free to unmute and add on to this as you wish.
Sure. Maybe I could provide clarification. So basically, I just want to know, when you're working with the interventionist, sometimes you don't get to choose which interventionist you work with. Especially, for example, for Sujira Muyongo, we work with a government workforce that is pre-selected. And so we've run into instances where the interventionists are resistant to components in our programming. And, a question for us has always been, how do we work with these interventionists or individuals to prevent them from, having a potential harmful effect on the families?
Yeah, that is such a wonderful question. And I think it is a situation many of us find ourselves in. slight tangent from that. I mean, we know that not everyone is going to love every intervention. You know, some are going to be good fits for some and not great fits for others. So just in your question, Ursula, you know, I always wish people had some choice to not deliver if it really didn't fit with them. Sometimes it's been helpful, as I'm sure y'all have done, to hear out what their resistance is to a particular element and if the intervention could be effective without that element. Because I think you're absolutely right, but if someone is really resistant to something and doesn't believe in it, they may not want to deliver it. The trainers and supervisors at ACE, they do a lot. If resistance is all like, well, this isn't how this is typically done, they will lead people through an activity where they'll call out a cultural norm, but then they'll ask for exceptions from the trainees or from the families, and then they'll use those exceptions to move forward. So one of the things, if the resistance is like, I'm not sure that this is appropriate here or will work in this particular context, they've kind of had this open conversation, pulling in examples around what people might have been resistant to. But in terms of how to prevent harm, I do think it's hard if people deliver something they don't believe in. So we have something called a construct innovation values fit, which is in a lot of the implementation models. And we were able to ask people about their values related to children who've been orphaned. You know, because there can be a lot of stigma for kids who've lost a parent to death. And so we have a questionnaire really looking at, does the innovation, which is trauma-focused CBT, help you advance your values or meet your values? And theoretically, people think that's pretty important. So in terms of how to prevent harm, I always feel bad when I don't have an answer, but you know, there's a part of selection into an intervention and intervention selection that if people are really resistant to an element, have you had any ability to have people not deliver that element, or is it there's a piece that they have to do?
So for us, the most common component is gender. So sometimes with our gender messaging, there's folks that don't believe in it or don't align with it. You know, we do a lot of peer-to-peer strategy to be able to kind of work with that, specifically folks in the same kind of demographic area of the other peer to kind of help do that. But we do have an option if someone does not want to deliver the program. We work with our government agency to see if they don't, you know, they can be replaced for the delivery, or if we could do something on the back end with the workload to prevent them from having to deliver. But yeah, as far as omitting a component, we don't currently do that.
And that makes sense. I'm glad I asked you what the intervention was, because it does make difference. So, you know, with component-based mental health interventions, sometimes maybe a piece could come out and maybe it's not as effective on the clinical outcome as it would be. But I see what you're saying. That's more of a belief. I know we have limited time, but I will say that folks doing climate change research have come up with some interesting ways to have people work together in small groups to solve problems that may change attitudes in an interesting way. I've been kind of interested in those strategies, because I do think if you have a true belief that is in opposition to an element of an intervention, so gender-based messaging, gender identity, gender expression, there's a difference than like, oh, I don't want to do this element. So I know that I'm not fully answering your question, but if it was easy, you would already have the answer. I'm sure that one is hard. I wish people did have choice to be in, because to be good at something, hopefully you believe in it and you want to deliver it and your values align with what you're delivering. We know we have great success there, and it's harder if we don't have alignment. I'd be interested in connecting on it later, because I know I won't have an answer, but these are the kind of problems we should be figuring out.
Absolutely. Thank you so much.
Okay. Do we have any other questions from other participants online?
Shannon, this is Teresa Vencourt. I'm so sorry I had to join late. I ended up double booked, but I am really honored with what you've shared with our lab, and I can see it's really got people thinking deeply. And I think on like the challenge that Ursula just described, because our home visiting intervention in Rwanda really does tackle some of these issues around gender and the roles of males and females in contributing to household success. And I know you have so much Africa experience. I was wondering, you know, how topics of gender have come up in your own work, and where, if anywhere, you've seen innovation around addressing some of these gender norms in sub-Saharan Africa, because we just, you know, love to be thinking about this more broadly.
Yeah, that's a great question. I mean, I think it would be very helpful to even have some further discussions on this together, just because in some ways, probably we have worked within some of the gender constraints, you know, like in terms of like gender matching and single gender groups. And, you know, in a functioning measure we definitely, if you had a sister, the way we measured success was different than if you didn't have a sister, because we had boys who did some household duties they wouldn't have done had they had a sibling in the home to contribute to just not household success as y'all define it, but just, you know, chores and daily things. I would definitely be interested in it. And I think even more than my answering, I think I would want to ask the ACE team what and how they've been able to do what they do. I mean, their calling for exceptions has been really important for things that are maybe not as culturally syntonic. So like talking about the person who died, or giving praise when a child does the behavior they're expected to do. So they have done a lot of like calling for exceptions and working with those. But now I'm going 2 for 2 with no answers, but I feel like I'm humble around probably not being the best expert, but interested in the conversation and very curious to ask my colleagues at ACE how it goes. And I know for even the women that lead our interventions, you know, they often are experiencing difference as women leads of the intervention versus male leads of the intervention as well. So, you know, and I do in my daily life at the university. So certainly gender and identity issues pop up a lot in terms of how we deliver. And, you know, it's certainly something we've got to figure out a little bit.
Yeah. Well, we have a lot of people online who are, you know, from our African teams, a lot of our Rwandan colleagues. If people have comments or thoughts on this, we'd love for you to chime in, because I agree with Shannon, these aren't easy to answer questions, and we're ultimately, you know, coming from outside the culture. But I do think it'd be really fun to get our sub-Saharan African teams in conversation, because I'll bet your staff have a lot of thoughts on these issues. And I know our team in Rwanda absolutely would as well.
Yeah, and I think the intersectionality too, like for some of our kids, like Tanda from yours, but you know, when they've had a parent die, they're orphaned and they're girls, like that double intersection, that intersectionality of identity can be hard for them from the client side.
Absolutely. Well, I see we're at time. It's been amazing, Shannon. We're just really so grateful. And I think we just kicked off a conversation. We'd love to have some follow-up with your team and our teams together, because I think we're all in it in the same space, and excited about what implementation science and collaboration can really contribute. And so thanks for coming. And Laura, do you want to close us out? You did such a great job.
Oh, I'll just echo with what Teresa said. Thank you so much for your time. And I feel like we're all in this space where we're in this gray area where it's not black and white, and there are really hard questions. And so it's nice to be on that journey with you, and then be initiating a lot of these challenging thoughts and questions that we all have. But thank you again for your time. I know it's very early for you, so we appreciate learning from your expertise this morning.
I'll go finish my coffee. Have a lovely evening and day, everyone. Thank you.
Thank you so much. Take care.
Bye.
You can finish.